Low back pain rehab often fails because you're given exercises, stretches or passive treatment before anyone has taken the time to try to understand what's actually driving your pain. If you're not shown the movements, postures and loads that provoke your pain in daily life, and you're not given a program adapted to you, it's no wonder you end up staying stuck in the same cycle. A lot of my clients believe they've already tried everything when I first meet them. But after I dig a bit deeper, this is rarely the case. What is extremely common is that they've been given generic treatments before they've been properly assessed. In this video, I'm going to show you why standard low back pain rehab keeps so many people stuck, and how a more in-depth assessment can reveal what your back actually needs. You'll learn why so many ineffective generic treatments continue to be given to people with low back pain. Then I'll get into the McGill method low back pain assessment I take my clients through, starting with why your personal history matters more than you realise. Because previous injuries, surgeries, work demands, training habits, and your individual anatomy can all contribute to your recurring back pain. I'll explain why your pain triggers need to be identified. If they're not, and you're given the wrong stretch or exercise, or you keep moving in the same way you've always moved, this can end up provoking the exact symptoms you're trying to calm down. I'll also cover the importance of spine hygiene. This is often the missing piece because even a good exercise program won't work if the other 23 hours of your day are spent repeatedly irritating your back without realising it. And you'll learn why your exercise program must be personalised, because the same exercise that helps one person can reliably cause flare-ups in another. Before I get into the details of the assessment, I want to make sure you understand the scale of the problem and why it's being managed so badly. Low back pain isn't rare. Depending on the population studied, up to 80% of people in developed countries will experience it at some point in their life. But for many people, it isn't just an occasional ache that disappears after a few days. It starts to affect how you sit, sleep, work and train, interfering with almost every part of your life, not just physically, but psychologically and emotionally too. But I believe that a significant percentage of these cases are completely avoidable. My clients have usually been living with low back pain for months or even years before they get to me. By that time, they've already tried physio, chiropractic, osteopathy, acupuncture or other alternative treatments. They've usually used up all the sessions on their insurance, but their back pain hasn't improved, and in some cases it's worse than when they started. Many of them tell me that about half of their treatment was spent lying motionless on a table while their therapist administered some kind of passive treatment, either with their hands or with a machine. And the other half was spent doing standard exercises or stretches. It's extremely rare, however, that they've ever had a thorough assessment before receiving treatment. One reason is that most cases of low back pain get classified as non-specific low back pain. That just means that the person diagnosing you hasn't been able to identify an obvious cause, such as a fracture, a tumour, or other serious pathology. So they give you the label of non-specific low back pain, which leads to you being given generic treatments like the ones I just described. So it should be no surprise to learn that last year, the biggest systematic review of its kind, of over 300 studies on low back pain, concluded that 90% of low back pain treatments don't work. 90%. I was interviewed for an article in the Telegraph about this study. The main point I made was that the fundamental problem with studies like this is the lumping together of different subtypes of low back pain into the same category of non-specific low back pain. Everyone then gets given the same treatments and they act surprised when most of them don't work. The problem is, as Professor Stuart McGill has repeatedly said, there's no such thing as non-specific low back pain, just like there's no such thing as non-specific knee pain or non-specific shoulder pain. Low back pain is very specific to the individual, which is why it's so important to conduct a proper assessment instead of giving the same generic treatments to everyone. But ineffective generic treatments are still widely used for a number of reasons. One, they're convenient to administer in a clinical setting. You can have someone give you a massage, apply some ultrasound or do some dry needling. It all feels like treatment, and as an added bonus, they're easy to bill on the insurance. Which leads me to my second point. 2, they're cost effective for the clinic. For some treatments, the clinician doesn't even have to be in the room with you. They wire you up to a TENS machine, or attach some suction cups to your back, or put you under a heat lamp, then go into the next room to deal with someone else. This is a red flag for me personally, because of the obvious financial incentive of the clinic to use these modalities despite the weak evidence of their efficacy. 3, they target symptoms. This sometimes makes people feel better temporarily, and of course people want to feel better. But temporary symptom relief isn't the same thing as addressing the root cause of your low back pain. 4, beliefs about evidence. Some clinicians believe that the disc bulge you can see on your MRI isn't relevant because so many people have disc bulges and they're often asymptomatic. So you're told, just do these stretches and mobility exercises anyway. While it may be true that a lot of people have asymptomatic disc bulges, it doesn't mean that the disc bulge you have isn't what's generating your pain. This is a bit like saying the nail in your tyre can't be causing the puncture because lots of cars drive around with nails in their tyres and don't lose air. You would still obviously assess whether the nail was in fact the cause of the puncture, in the same way that you need to assess whether the disc is the likely cause of your pain. I know these beliefs are common because of the number of my clients who have routinely been given exercises that clearly aggravate their sensitised disc bulges. 5, finally, behaviour change is hard. It's much easier to lie on a table and receive treatment than it is to change how you sit, bend, lift, train, walk and recover every day. But if those daily habits are part of what keeps provoking your pain, passive treatment alone is never going to be enough. The main point to remember here is that if you don't address the root cause of your low back pain, you should expect it to keep coming back. Now, let's get into what I cover in the McGill Method low back pain assessment that I take my clients through. The full assessment takes 3 hours to complete because that's how long I need to cover the points I describe here in detail. Your personal history matters because your back pain today can be influenced by things that happened years ago. Previous injuries, surgeries, sports you used to play, repeated movement patterns you engage in while at work or in the gym, which treatments you've already tried, not forgetting the limitations of your individual anatomy. Too often, important details are skipped over, which leads people, through no fault of their own, remaining ignorant about the true cause of their low back pain. Daniel's case is a great example. He came to me with low back pain that he'd been dealing with for years. His MRI showed that he had a herniated disc in his lumbar spine, but the standard physio treatment he'd received hadn't helped him get rid of his pain. During his assessment, I noticed that when he squatted, his knees didn't come very far forward. So I asked him why. He told me that he'd been born with club feet and had surgery to correct them when he was a baby. The surgery was a success, but it had left him with only around 20% of normal ankle dorsiflexion, which is the movement where your knee travels forward over your foot. So when he squatted, sat down or bent down to lift something up, his ankles didn't give him the movement he needed, which meant he had to find that movement elsewhere in his body. This inevitably ended up coming from his back. He had to round his lower back into flexion every time he sat in a chair or bent down to pick something up. I'm not suggesting that everyone should completely avoid spinal flexion, but if it's your default movement pattern every time you sit, squat or pick something up, especially if you're lifting something heavy, that repeated flexion and compression can gradually delaminate the outer layer of the discs in your lumbar spine. And over time, with thousands of repetitions, this can lead to a disc bulge or herniation, which is exactly what had happened to Daniel. None of the doctors he'd seen had made the connection between his lack of ankle mobility and the herniated disc in his back. It was only when I pointed this out to him that he was able to start doing something about it. Fortunately, over a period of weeks, we were able to improve his ankle mobility, which enabled him to squat lower while keeping his spine in a neutral position instead of having to flex it every time. This reduced the stress on the damaged disc and allowed it to begin healing itself, which eventually got rid of his low back pain. No amount of passive treatment would have helped Daniel get rid of his low back pain. It was only when we addressed the root cause that we could find him a long-term solution. Provocative pain testing is where we identify which movements, postures and loads trigger your pain. This allows us to understand what your back currently tolerates and what it doesn't. Because two people with low back pain may need completely different approaches. One person might be aggravated by flexion and another might be aggravated by extension. One person might not tolerate sitting, another might not tolerate standing or walking. One person may need to brace their abs more to stabilise their spine, while another may need to relax more. This is why generic exercise programs are so hit and miss. A useful example is the difference between someone with a dynamic disc bulge and someone with lumbar spinal stenosis, which basically means a narrowing of the space through which the spinal nerves pass through. Both people can experience low back pain and have radiating symptoms down into their leg. But the movements and postures that provoke their pain can be completely different. So one person with disc-related radicular pain might be aggravated by repeated flexion or sitting for too long. This happens because when they flex their spine, the hydraulic pressure in the disc increases stress on its damaged posterior wall, which pushes out and compresses or irritates the nerve root, provoking radiating symptoms in the leg. Whereas another person with lumbar spinal stenosis will often feel worse when standing, walking, or extending their spine, and feel relief from their pain when they sit in a more flexed position. This is because when they're extending back, or even just standing upright, there's less space for their already cramped nerves to pass through, so they get compressed and trigger the radiating symptoms down into the leg. But when they sit, the nerves have more space and their symptoms subside. It should be obvious that these two people shouldn't be given the same exercise program for low back pain, because it would be pretty much guaranteed to include movements that provoke pain in at least one of them. A concrete example is my client Remy. Since his low back pain had started, he'd noticed that the back of his left leg had tightened up. He was given hamstring stretches by his physio, but these only seemed to make his back pain worse. When I conducted his assessment, I got him to do a straight leg raise when he was lying down on his back. He could only lift his leg to about 30 degrees before tension in the back of his leg and pain in his lower back stopped him from lifting it further. Then, when he dorsiflexed his ankle, so pulling his toes towards him, his pain increased. That was an important clue because the hamstrings crossed the hip and the knee, but not the ankle. So this confirmed that the increase in pain he felt was because of tension in his sciatic nerve, not his hamstrings. That meant that every time he'd been doing what he thought were hamstring stretches, he had actually been cranking on his sciatic nerve, which was keeping him in a cycle of pain. More testing revealed that he was able to move the nerve along its path without provoking his pain when we coordinated the movement of his head and his lower leg. So that told us that nerve flossing was an appropriate therapeutic exercise for him. And after only a couple of weeks daily flossing, combined with his personalised exercise program and consistent spine hygiene, we repeated the leg raise test. This time he could raise his leg to almost 90 degrees. He had essentially tripled his range of motion without doing a single hamstring stretch. Many of my clients come to me with similar stories. They're doing exercises that aren't appropriate for their specific problem. So it's no surprise they're still in pain. If there's a movement that reliably provokes your symptoms and your rehab program includes that same movement again and again, your back pain isn't going to improve. But identifying your pain triggers is only useful if you then consistently stop provoking them. And this is where spine hygiene becomes so important. Spine hygiene means removing the repeated movement flaws and daily habits that keep stressing the irritated tissues in your back. Most people underestimate how important this is, because your rehab exercises might take about half an hour, but your back then has to get through the other 23.5 hours in the day, including how you sleep. If that time includes repeated actions or postures that provoke your pain triggers, then your exercise program is fighting a losing battle. Another one of my clients, Manjeet, had lived with chronic low back pain for 7 years. He had seen doctors, physiotherapists and acupuncturists, but he couldn't get rid of his pain and nobody had been able to explain why. He would experience sporadic spasms in his lower back muscles, but he didn't understand what was triggering them. It seemed to him like this was just something he was going to have to live with for the rest of his life. He was even expecting it to get worse as he got older. Then he came across the work of Stuart McGill and was referred to me because I work with people online using the McGill method approach. When I watched how Manjeet moved, it was clear that he was repeatedly provoking the same pain triggers that had been identified during his assessment. He was flexion intolerant, which means his pain was provoked when he bent forwards, putting his spine into flexion. But he had never been taught how to hinge at the hips as an alternative movement strategy to reduce the stress on his spine. So, every day without realising it, he was irritating the same pain trigger again and again. When he sat down in a chair, when he got out of bed, when he picked something up from the floor, even when he walked upstairs, he was repeatedly flexing his spine and irritating the herniated disc that he had. Flexing your spine might seem like a harmless movement, and it is for many people, but when you have an irritated disc that's sensitive to repeated flexion, those ordinary movements can become a constant source of pain. And another problem for Manjeet was that he didn't always feel his pain immediately. It was often the accumulation of poor quality movement throughout the day that eventually crossed the tipping point and presented as pain later on. To stop this from happening, we worked on his spine hygiene, so teaching him how to move in a way that didn't stress the sensitised tissues in his spine. And a key part of this was showing him how to hip hinge. This is where you put your spine in a neutral position, brace your abs to stabilise it, and then move through your hips. We applied this to how he sat down, how he got out of bed, how he picked things up, how he walked upstairs, so he could get through his day without cumulatively aggravating his back. This finally gave the disc in his back the chance it needed to calm down and become desensitised. And he saw significant improvements in pain reduction within a few weeks. Then, over the following months, we gradually expanded his ability to do strengthening exercises in all the major movement patterns. And within 6 months, he no longer had any low back pain. The last time I had a conversation with Manjeet was over 3 years ago, but I recently checked in with him and he told me that he's still doing the training program I gave him and his back is still doing great. All because he understands what was provoking his pain, he stopped repeatedly irritating his back, and he's improved the endurance and strength of the muscles that protect his spine. Another client of mine, Laurent, had suffered what is known as an iatrogenic injury, an injury caused by medical treatment. He went into an osteopath's clinic with low back pain and came out with low back pain plus sciatica, which he experienced as sharp shooting pains down the back of his leg. Without conducting a thorough assessment to determine the source of his pain, the osteopath had asked Laurent to lie on his side and perform the same manoeuvre you can see here. This forced rotation through his lower lumbar spine right around the area where he already had a herniated disc, provoking the shooting pains down the back of his leg. In the months that followed, Laurent was beginning to get back to normal after working with a physiotherapist. However, when his physio gave him the prone scorpion exercise as part of his rehab program, it triggered his sciatica again. And if you look at how the pelvis rotates at the base of the spine during this exercise, it should be obvious why. It's basically another version of the osteopathic manoeuvre that injured Laurent in the first place. When Laurent first contacted me, he had started to lose hope he would ever find a solution for his back pain. I told him that carrying out a thorough assessment was the best way to figure out a way forward for him. We did the assessment and it was clear that any kind of movement where he twisted his rib cage away from his pelvis was a pain trigger for him. So if I had then given him a generic low back pain program that included exercises with the same rotation or twisting pattern, like those you often see as a quick fix for low back pain on Instagram, I would have been feeding the problem, not solving it. Instead, we had to adapt his program around his pain triggers. We chose exercises that improved the stability and control of his spine without reproducing the movements his back couldn't tolerate. And after 6 months or so, Laurent was pain-free and doing swings with a 32-kilo kettlebell. I got in touch with him again recently, so about 2.5 years since our last session, and was happy to hear he's still doing well, training without pain by following the same principles he learned while working with me. So if your low back pain rehab hasn't worked in the past, it doesn't mean to say you're a lost cause. It may well just be because you haven't had a thorough enough assessment yet. If you've been given treatments or exercises before anyone's taken the time to try to understand the cause of your pain, then it's understandable that you haven't found a solution yet. The most important thing to remember is you have a much better chance of getting rid of your low back pain when you understand its cause, you learn how to avoid provoking your specific pain triggers, and then you build resilience through an exercise program that's been adapted to you. And that can only happen if you get a proper assessment. If you want to find out more about how you can work with me, either one-on-one or in the group educational cohorts I run, click the link in the description to find out more.